pregnancy? Is it increased gastric acid secretion, that is HCl, reduced progesterone levels? Pregnancy ni gani? I'm seeing C, 58C, but there's a D also from dictator. We have C and D. Yo, man, it's paper 2 BSN. So 50, midwifery ni paper 1. Oh, well, maybe arrangement za maswali basi, but ililebeliwa paper 2 ya NCK, but tufanye tu. So 58C evidence says hizo contents of the contents of the abdomen zinakuwa pushed up, si ndio? Zinakuwa pushed upwards, inakuwa loose kutoka hiyo. Thank you for reminding us, but tufokasini sawa, ndio pepa tuko nayo, Third eye umerudi? Oh, pole, welcome back. Hebu chukua mic uendelee.
Thank you. Thank you. So hiyo namba tushasiti. Habari yako ni Mo, my baby. Haya, kuna evidence imetumwa hapa na sijui kuna mtu anaongea. Kuna mtu anaongea sijui mi nasikia vitu zangu. So there's an evidence the area that reads pressure. Let me see, the angle of the gastroesophageal junction is altered, and the lower esophageal sphincter is displacing effects of the progesterone, which reduces gastrointestinal transit, all contribute to the reflux of the gastric contents into the lower esophagus, leading to heartburn. Gas pH and the volume in pregnant and non-pregnant women show no difference in the proportion of the women meeting at-risk criteria. By Mickey, the gums become edematous and easily bleed. The salivary glands are more active, leading to increased salivation. There is thank you very much, Eugene. We have the hormonal changes. The hormonal roller coaster of pregnancy can have profound impact on the digestive system. Increased levels of hormone progesterone relax the lower esophageal sphincter, a ring of muscles that opens to allow food into the stomach and then tighten episodes. So with that, you can give me cities. I hope we are together. So thank you very much. Kindly forward the next question. So the next question is number 59. Which fetal presentation is most associated with cord prolapse? Which fetal presentation is most associated with cord prolapse? A. Vertex, B. Bro, C. Bridge, D. Face. So attempt number 59. So we have 59C. So the most the fetal presentation that is most associated with prolapse is, why is it associated with what is the rationale? Why? What is the reason behind it? Also, we have A. A is a vertex. Also, you can give me the rationale. Ill-fitting presenting part. Ill-fitting presenting part in breech. So, thank you for those insights, Julie and Maureen. So according to the breech, because of failure of the baby to fully rotate, which may lower the position of the cord. Okay. Is there any evidence to justify the cord prolapse? The cord lies in front of the presenting part, inside the vagina, or outside the vulva following rupture of the membranes. Cord presentation is the presence of one or more loops of umbilical cord between the fetal presenting part and the cervix without membrane rupture. Occult cord prolapse. The cord lies alongside but not in front of the presenting part and is past the presenting part and is lower than the presenting part in the pelvis. Thank you very much, Kathy. Then also we have more evidence shared by Obonyo Eugene. Overt prolapse occurs with ruptured membranes and is more common with breech presentation rupture, spontaneous or iatrogenically before the head is engaged. Treatment of overt prolapse begins with gently lifting the presenting part and continuously holding it off the prolapse cord to restore fetal blood flow while immediate cesarean section is done, placing the woman in a nichest position and giving her by reducing contraction. Thank you. More evidences shared here by Sino. Thank you. Malpresentation cord prolapse is associated with breech presentation, especially complete or footling breech, umbilicus in the buttocks. So in this situation, the degree of compression may be less. Evidences, I think you bandit. So you can give me cities. If unafanya artificial rupture of the membrane, hufai kutoa mkono immediately because amniotic fluid can sweep out the cord. So kindly for the next question. So far we are cruising nicely. Share the next question. 60. Which postpartum assessment best evaluates uterine tone? A. Measuring lochia amount assessment best evaluates uterine tone. So I can see we have B. Most of you, if not all of you, are going with B. So back to the question. Fine. Okay. Okay, thank you. So it's like all of you are going with B. So I will not go deep into it. I will not go deep into it. Why do we assess lochia? Okay. Or to rule out PPH. Okay, thank you. And an update scholarship. this highlights the reproductive system, the uterus. So we have an involution is the return of the uterus to a non-pregnant state after childbirth. Involution process begins immediately after expulsion of the placenta with contraction of the uterine smooth muscles. At the end of third stage of labor, the uterus is in the midline, about 2 centimeters below size it was at 20 gestational weeks. The fundus descend about 1 to 2 centimeters childbirth. So subinvolution, uterus remains large, does not involute. Signs are lochia fails. The treatment, we have methagyne, then curettage, antibiotics. Prevention, you do a risk assessment, inspect placenta, explore uterus, avoid over manipulation of the uterus. If at risk of type and X match, and start IV. Okay, thank you. Thank you very much, Hami, for updating it. Thank you for this question, kindly. Let us proceed. Number 61. Which maternal sign most indicate hypovolemic shock, bradycardia, CCCC? I'm trying to scan through to see if there is any contradiction. Kindly number your work. Corrected by IV fluids and blood transfusion. Okay. So we have C and B. C is tachycardia and hypotension, and then B is bradycardia. Insight. So meanwhile, you can share that evidence that was shared by Dragonas earlier. You can share that evidence that was shared by Dragonas earlier. Blood volume. If mesopitia shocks and their signs and symptoms, please, bradycardia is a late sign. Thank you very much, Kathy. So we have the shock. So shock is a circulatory failure due to hypoperfusion that leads to inadequate oxygenation enough to cause tissue hypoxia. Cells go to aerobic, causing lactic acidosis. Then the next stage is stage 2, that is compensated. Then we have progressive blood volume. Then we have cardiogenic shock due to insufficient cardiac output. Then we have obstructive shock, mechanical obstruction, distribution of blood to tissues and organs. Then we have septic shock, system to loss of communication between the. So I think, thank you for sharing this. Thank you for sharing this, Kathy. Thank you, Kathy. Thank you, Kathy. So you can note from this evidence shared by Kathy from burns or trauma. Treatment is by IV fluid therapy, oxygen therapy, blood transfusion may be required. We have increased respiratory rate, shallow respirations. So later you will have oliguria, confusion, restlessness, cool or clammy skin. So are we together? Are we together now? Neurology. Okay, thank you, Pookie. So I think with that now we can CT. Kindly do so. When we were rotating in a maternity, there's a facility that they are separated by. I took from theater after CS and took her to the ward. I did not receive. I just handed over to my colleague. So later, my colleague was the patient. Are you guys hearing me? Ama najiongelesha. To the ward after conducting a CS. No, after the CS was done. After the CS was done, the patient developed. This is based on true story, something that occurred. So my colleague was doing vital signs for this patient because the patient was complaining of thirst. The patient was very thirsty. The blood pressure was not reading. He did it for. He repeated the vitals. Assumed. The in charge assumed 8 readings that were not clear. Anyway, let us proceed. Hiyo story nitamalizia baadaye. No. To my next question kindly. So the next question is number 62. So I hope now you know that the most indicative signs of hypovolemic shock is 62 reads. A neonate with jaundice on day 5, who is otherwise well, most likely has. A neonate with jaundice on day 5, who is otherwise well, most likely has A, pathology, D is sepsis. 62C. Hii story lazima niwamalizie hii story leo. I will not be carrying over stories. Na kuna students hapa ni wakali sana. Unaanza tu story hivi mtu ashajam. When we see that is a physiological jaundice. What is a pathological jaundice? A comes first within 24 hours. Yes, within 24 hours. What is the complication of jaundice? So yes. Also, this is so when you are in the newborn unit, you should not early enough. Alafu mtoto akiwa kwa phototherapy, you will note that at some time they develop a very high fever. Very not high fever.
We have
they will develop
body
fever
systems
because of
let's clap for him.
Phototherapy.
Thank you very
when
much.
I was in NBU, this
we have nervous system, respiratory system,
that,
cardiovascular system. We also have hematological system,
even though
or digestive system,
develops fever,
musculoskeletal
never
system,
stopped of the
immune systems,
switch of the
endocrine systems, and lymphatic systems. All these 12 systems forms an organ. Our systems, we will provide or conduct a focused.
So what is the difference between hemolytic and physiological?
Straight to the point.
Physiological within
systems
24 hours
that
after
are
delivery
most probably or could be
resist more
probably
than
be
14 days.
affected by our
Physiological
chief
jaundice
complaint,
are
surgical history,
215
including the
and do
social
not
history,
exceed
that is the
250.
lifestyle.
EU
So,
mol ni nini? Neonatal jaundice.
We have obtained.
Neonatal jaundice
Someone
is the
please
yellowish
kindly
discoloration.
mute your microphone.
So neonatal jaundice is the yellowish discoloration of the skin, sclera, and the mucous membrane in newborns due to hemolysis, decreased hepatic conjugation, immature liver enzymes, increased enterohepatic circulation, infection, metabolic or genetic disorder. Clinical features: we have yellowish discoloration of the skin and sclera, poor feeding, lethargy, in severe cases, high-pitched cry, seizures if kernicterus develop. We have types of neonatal jaundice. We have physiological jaundice, appears after 24 hours, peaks at 3 to 5 days, resolves within 1 to 2 weeks. Pathologic jaundice appears within 24 hours of birth. Hemolytic disease, that is rhesus incompatibility. So we have infection, prematurity, liver disorders, breastfeeding jaundice, early onset due to poor intake or dehydration. Breast milk jaundice appears after 5 to 7 days, may persist for weeks. Complication: we have kernicterus, bilirubin encephalopathy, that is irreversible brain damage. Physiological jaundice is the main treatment, jaundice and breast milk jaundice, so that we can proceed. Mnipe city jamani, sioni city ama network yangu ndio mbaya. In NBU, you find that the blood group or mothers, babies develop jaundice in the ABO. You are asking, okay. Difference between breastfeeding jaundice and the breast milk jaundice. Breastfeeding jaundice is the result of baby not receiving enough milk to lower their bilirubin levels. This causes the bilirubin to be reabsorbed into the intestines and keep the levels elevated, which triggers jaundice. Breast milk jaundice, the cause of breast milk jaundice is currently unknown, but doctors believe it is linked to this to some type of substance that is in the breast milk that inhibits the liver's ability to break down and process bilirubin. This type of jaundice has been known to run in the family. So naona mmenipea cities nafurahi sana. Tuma next question. So it is advisable that mwanaume in your reproductive age usipende kwenda kufanya kazi NBU. NBU is not for men in their productive age. This question kindly. Ni number? Tunaenda number 63. Somebody to answer she. So somebody to answer she. Ebu she kindly butage swali yako tena. The rationale is because of the temperature. See, nothing much. The temperature in NBU is always very high. Wanaweka the temperature very high so that I don't know, inakuwa sijui how many temperature. Nakumbuka nikiwa NBU, it was very hot. It was very hot inside there. Na the windows are always closed. The windows are always closed. So unasikia tu hiyo joto yako kuingia shift mpaka utoke. Ukifanya of being in the NBU unazaa watoto wako na deformities, utazaa madwanzi. Aya, iko wapi nini? Iko wapi swali ya nani? Let me address swali ya she. Ilikuwa she. In NBU you find that. Can somebody kindly answer this? Usikae. In case unafanya kazi in BU na unataka kuzaa kama mwanaume, inafaa uende ufanye like you hizo. Hakuna mtu akona, hakuna mtu anajua that kuna swali fulani hapo ilikuwa Tuma next question. Which complication is the most associated with placenta accreta? Which complication is most associated with C, preterm labor, D, cord prolapse? Huyu nani amejibu before nimalize kusoma? Nani huyu amejibu before nimalize kusoma? Takuchomoa. So now ended up B.
We look at the surgical assessment. These are assessments that are related to surgical procedures.
Everybody is going with B.
For example,
B reads,
the type of surgery that has been.
Back to the question. Which of the following complication is most associated with placenta
post-op status? For example, then patient clean. Is it dry? Is it bleeding? Is it blood stained? Is it offensive? Is it intact? This is where all this gets in. And please clearly state how many days post-op for that assessment. Focus here on the surgical invasives. If a surgery was conducted and there is something that was inserted to drain, like surgical drains, post-op tubes, this is where we write.
So where were we? Kila mtu ame. So what is the concern? What is the concern? Which of the following is the most associated complication associated with placenta accreta? What is placenta accreta? What is placenta accreta? Can somebody kindly share something on the same? Evidence iko hapa. Placenta accreta. Mommy's pride, can you read that? Can you kindly read it? Placenta implants too deep. Placenta attached too deep into the uterine wall. It is a condition in which the placenta implants deeper into the uterine layer. So placenta accreta on the myometrium uterus then outside peer involving the bladder or any other organ. Give Sione cities. Give me cities. Give me. I'm counting. Oh, this one is even better because now note the various. We have the Accreta, we have the in Accreta, we have the percussion. Kindly. Oh, no. Thank you, Mommy's Pride. So Accreta, thank you very much, Mommy's Pride. Why am I not seeing the next question? Mtu wa maswali amelala. Simpigie hata Mommy's Pride makofi jamani. Mreact hapo na makofi. Next question kindly. Mtu wa maswali, kwani mtu wa maswali amenyakuliwa ama nini? Una forward hadi makofi. Okay, thank you. Which assessment findings suggest maternal sepsis? Which assessment findings suggest maternal sepsis? A. Normal pulse. B. Hypothermia. C. Foul-smelling lochia. D. Increased appetite. Attempt. C. Yes. Next. Oh, we need evidence. Somebody to kindly share evidence. Somebody to kindly share evidence. But hiyo haina evidence. Mshanipea CT. Too many. Next question. Emergency requires immediate elevation of the presenting part. A. Shoulder dystocia. B. Cord prolapse. C. Uterine inversion. D. For the question of CT, B. Presenting pattern will help to thank you. So I think with that we can proceed now. Use ni kama baridi imeniingia. Which factor? C. Teenage pregnancy. Very many attempts. Nitumie swali hapa chini. Kindly. Sijui mnaweza kuwa mna tag history of mental illness. So factor to puerperal psychosis. So nitawatoa, ufai kujibu na kuchomoa juu au follow instruction. So what about D? What does factor to puerperal psychosis? Puerperal psychosis ina happen after how long? Of the same, highlighting the blue shared this antiquity. It leads to hospital. So these factors may have suffered from, may have adversity is condition. All social those live on post classified in our small problem. Depression, big problem. The safe ask earlier. So 10 days of signs, not delusion. Then 30 panic, interest, longer maternity leave, follow-ups. Then risk factors is inhalations. Intervention is required. The causes, that is hypopsychotics, mood keeps limited. Anyway, thank you. So mnipe CT tuendelee. Please, time. Avoid unwanted time. Ni when you are avoid unwanted time ni when you are ready, when you are ready to do it. Ile time akili yako itakwambia you are ready to do it. It's the best time to conceive. Usiconceive with hiyo mtoto atakuwa mtoto. Hautapenda avoid knee chest, avoid kuconceive mtoto na knee chest jamani. Have decorum. And ningesema last, the best position for conceiving a baby probably it is not knee chest. Conceive a baby in a sex position that is a but anyway, where's the next question? Results from extraction during delivery. A. Kapu head ama kapu cesadenum. And then we have abs palsy, we have neonatal jaundice, we have hypoglycemia. So 67B BBB. That which the lower arm, the lower part of the arm, which upper the clamps ama clamp kiss lower. It is the C5 and the C6. Ni C6 ama ni C7. What about clamp? Meiva. Next 68 on placenta previa. Thank you very much, Cinnamon, for that insight. So I can see mnaenda na B. Yani leo every question napatana na story ya kuambia. B ilikuwa placenta previa. Presenting with a painless. So my friend, mnipe CT nikiwa. Then all of a sudden inafika bila kuambia. All of a sudden inafika bila kuambia. Graduate kwa tumefutwa kazi. Sometime anatuambia la saa alitaka kutoa but hivi karibuni dem alifanya scan. The guy is happy. Dem alifanya scan. The guy is happy because they are evil outside here. Next, happy because they are evil outside here. Next. Sasa namjua. Next. Sasa namjua. Next question is number 6. Which nursing action is most? Question is number 6. Which nursing action is most rupture from? A. Immediate induction, anal move. A. Immediate induction, anal movement. D. Administering oxytocin immediately. I can see you guys are going with B. Pre-labor premature rupture of membrane. Thank you very much, Ro. Thank you very much, Ro. So unstable and she's outside. So so below 37 weeks, that is a pre-labor premature rupture of membrane. Then premature rupture of membrane is after 37 weeks. Inasemaje? Monitoring for signs of infection. Yes, that is true. What might cause is it prolonged premature? Is it prolonged or pre-labor? Ni pre-labor, okay. So it is pre-labor premature rupture of membrane. What might be? Hey, jamani mnatukon. So okay. Thank you for those insights. Thank you. Able to many tunasema ni pre-labor. Yes, it is a preterm pre-labor occurs before 37 weeks. So it occurs spontaneous uterine action and the consequential cervical dilatation. So the risk factors, we have imminent labor resulting in preterm birth, chorion amended promptly, then oligohydramnios if prolonged. These are the risks of associated with prematurity and neonatal outcome and prolonged term hospitalization. Increased incident same, the woman will be admitted to the maternity unit. A careful history is taken and rupture of the membranes confirmed by sterile speculum examination of the pooling of liquor in the period will also offer a reasonable conclusive diagnosis if urine leakage has been excluded. Fibrinolectin immunoenzyme test is useful in confirming rupture of membrane and the reduce the risk of introducing infection. Observations are made of the fetal condition from the fetal heart rate, as an infected fetus may have a tachycardia and also a maternal or offensive smelling vagina. So thank you everyone who was sharing. Preterm, pre-labor premature rupture of membranes before term, but premature rupture of membrane can be even within term period. Next question. So the next question is number 70. Which sign best indicates fetal hypoxia? Late declarations. And then, and then accelerations. Which sign best indicates fetal hypoxia? Baseline variability, early decelerations, late decelerations, accelerations. C. Anyone with contradicting answer? Yes, so we have B, C, so already we have some evidence from Sino. Thank you very much, Sino. Baseline varies over the period of a minute. The baseline variability is under the influence of the autonomic nervous. If repeated acceleration should not be reflected as a fall in the baseline rate on the late of at least 15 beats per minute for at least 15 seconds, are rare and benign and are therefore not significant. Most decelerations in labor are variable, which means they are variations typical and atypical. Typical variable decelerations occur in response to intermittent cord compression and are commonly recover to the normal, which is a normal physiological response to intermittent cord compression. A typical variable, all of the following features: loss of accelerations before and after deceleration, delayed recovery, bound tachycardia, loss of these decelerations are uncommon and are usually considered to be indicative of fetal hypoxia. The main features are being reduced variability, repetitive and uniform shape, begin at or after the peak of contraction, Their lowest point is 20 seconds or more after peak of contractions. These parts or more. Significance of the absence of accelerations is an otherwise normal trait. All 4 features of fetal heart rates pattern are assessed and an overall classifications of normal, suspicious, or pathological is determined according to how many features are described as reassuring. None box there. It is important to record the classification of trace at each assessment, as the actions required will be informed, intermittent, or auscultation every 15 minutes. Thank you for sharing that evidence. So somebody's mic is on. There was something that happened the last year's incident. Mtu invite her in kindly. Anakula carrot. Unipe siti. Mzee Mofin ako wapi atupe wisdom the remaining? Yes, you can give us wisdom the remaining 30 minutes. If you are in a position to speak. Yes, I know. Tuma next question alafu Mzee Mofin asiti. Next question ilikuwa namba gani? Tukingojea Mofin.
Huku unasema kuna nguzo.
Sijui ungeacha tusikie huyu mtu anasema nini. Ungeacha kwanza tusikie. Yo. Mwenye amemute umetukosea sana. Mwenye amemute success umetukosea. My ears were wide open. For the question hapa chini. 71. So Mzee Mofin, if you are ready, you will just raise your hand nikuachie mic. Which postpartum complication is most associated with prolonged catheterization? Which postpartum complication is most associated with urinary tract infection, mastitis, DVT? So attempt. Naona Mzee ati
I will take I hope I'm clear. Mnanipata? Able to hear me? Yeah, I think that one is enough. So thank you so much. I have at least to assist you for this little time. Yes, Inadesh, how are you? Yes, so I'm going to take this. I have 25 minutes to take you through this section. So let us just participate. I'm Mofin Sulfate, born in 1969 for the new members. I'm born January 1969. Now you can guess the years. Okay, anyway, can someone send the question? The next question. It has been a while. How are you? Sina mbona kona kesi. So, nipate the next question. I'm a geriatric couple. I'm the oldest person in this group. You that one should stick in your mind. I'm one of the oldest person here. So 271, which says, is it 271 or 272? Am I to tackle 271 or 27? I think I'm to tackle 272, right? Says it's raining here heavily and it's extremely cold. So I'm trying to struggle with the cold. So increased red blood loss. So this is called the physiological anemia, or what do they call dilutional whatever. So majority of you are endorsing option D. But therefore now, who responded by saying this because you are many, you people are many and many. Going this time, I think this is the cohort that contains a lot of people, but that is okay because you are revising for your exams. But this is the first time I'm coming across a very large cohort. Yeah. So, but anyway, so I can see you of that. What happened to the red blood cells? Yeah. What happened to the red blood cells? What do you call that type of anemia? What's it called? Oh my God, it's extremely cold. So, which of the physiological changes in pregnancy lead to dilutional anemia? So, hemodilution. Yeah, I thank you so much. Yeah, so there's something we call in physiology of anemia, in pregnancy, in relation to pregnancy. Yeah, we call the hemodilutional anemia. Thank you so much. So, what happened? Really? Uncle William. Okay. So what happened, or how do you describe the pathophysiology, or the pathophysiology of dilutional anemia, or the so-called the hemodilutional anemia? This part is so important in regard to pregnancy. So what is the pathophysiology? 32 weeks, right? Someone to invite Manita, that's her May. Someone to invite her. Someone to. What is the pathophysiology of the same? What is the pathophysiology of the same? Wow, thank you so much. So I just want to read this one: physiological anemia of pregnancy. So increase of blood plasma in pregnancy. Oh my God. Causes a state line, reaching the lowest in the second trimester unless the HB reduces such that to an extent that iron deficiency anemia results. Wow, thank you so much. Who sent that? Nana ametuma evidence kwanza. Saino. Oh, karibu niseme sinamo. Okay. Saino, thank you so much for that. And then some evidence sent by who? By Vicky. Vicky, thank you so much. Or the Hamei, someone to invite, because Providence, you are just making some. So thank you so much. That is regard to now this hemodilution that occur in pregnancy, physiological changes during pregnancy. So someone is saying hemoglobin levels increased by 18, while plasma increased by 50, hence leading to hemodilution. Yeah, you have to, your pathophysiology will be based on the RBCs and the what? The plasma. Good. Tuko sawa? Are we good on that? And yeah. There's a cohort. There was a time a cohort used to. Those people used to every evidence. They just what do they call? They pin every information. They also make summaries of the things. Used to do this. Maybe I'm not that. I mean that question that it was repeated on a several trial. So those are they make some summary of the most repeated questions, and then one person send it here. Still, Hamea, I mean, she's lost. Oh my God! Somebody is saying kompe na kizungu mingi. What do you mean, Kimadi? Kimadi, what do you mean? So somebody is also just read by ourselves. I think we are just relating to the same. So that's all about the. So you can also make summary of the same. Yeah. You can also make a summary of the same. Kindly. Don't hesitate. The next question. Can I get the next question? Mm-hmm. I don't understand what does it what Kenya namaanisha sielewi bado. Bado sijaelewa statement question 72 so 73. Can I see it? 273. Nini amwelewi? I was just saying, just make use of every evidence that's being sent here. Make summary the most repeated question. Kindly, I'm tackling questions. I might not read the irrelevant comments. Kindly. So Nico 73. Can I sit it to 73? Yeah, thank you so much. So 73. Yeah. So 73. Which neonatal hypovolemic and then congenital infection. So, which of the following are complications most common in infants of the diabetes mother? Rule number one. My rule number one. Who can guess? My rule number one. My rule number one. Kindly don't answer unless kindly don't usijibu swali mpaka nimalize. Kindly, especially for the new members. If you are new here, kindly don't answer until mpaka nimalize kusoma swali. It gives us some different impression. For the new members, I know you are many here, but kindly, please. And the old members also, wenyeji, kindly enlighten the rest of the new members. Kindly. We are many, let us tell them, because we will be having visitors every day. What is our norms here? Yeah. Yeah, thank you. So, kindly don't answer mpaka nimalize kusoma. Because it gives me some impression when you answer. It's like maybe you did that question on several times, or you also have an answer within yourself, and it might not be a discussion in that context. So, majority of you are endorsing option B. Can you get an evidence? So, what comes into our mind when you are saying, or when you talk of what happens, mothers? What comes into our mind? Or implications. So thank you so much. So somebody hyperinsulinemia. So let me just read some evidence that's been shared by Taino. In the utero, the fetus produces high level of insulin to manage the mother's high glucose. Yeah. So once the cord is cut, the glucose supply stops, but there's a good explanation. Thank you, Saino. Are you lost, my love? Or I give you my phone to moderate it. Please don't draw stones to me. So, are we good with that? Still, we need some evidences. So, can someone share something on the same? Oh, somebody saying we repeat 69, eh? It's okay. What about the feeding pattern? Somebody saying babies of diabetes mothers should be taken to NBU for blood sugar monitoring. Is it routine? That's a general point. Yeah. Hiyo point inakaa rumors kidogo lakini pole. Kusema you can take a baby to the NBU. Yeah. So anyway, so you have also to think because of what's happened. I think somebody has just explained the maternal circulation, cut off even after delivery. So somebody else shared, say no, thank you so much. Thank you. So care of the baby at birth, there's some intervention that has been put here. Thank you so much. And may God bless you for that. All babies of diabetes mothers are admitted to NBU. Yes, we are baby. What the beautifuls and the handsomes here. Thank you. So, 74 purity, excess pharynx, and then dry peeling skin, the large placenta, and then polyhydramnios. So, which findings most suggest prematurity? So, excess pharynx, then dry peeling skin, large placenta, and then polyhydramnios. Hata sijamaliza kusoma. Sawa tu. Haya. So, you are endorsing option B. You want me to end the session before 7 minutes? Yes? Yes or no? You want me to end the session before 7 minutes? Just tell me yes or no. Kindly don't answer unless mpaka nimalize. Usijibu swali mpaka because before hata nisome options mshajibu. Oh, nilikuwa nishamaliza. Remember we are doing discussion. Yeah. We are doing discussion. Yeah. So jataona mmeiva excess. So tupeleka wote na no problem. Nifanye tu nasikia to next question with your permission. Can I get one of 5,000 CTs? Someone. Thank you so much. So I think we are done for the little time. Sawa May. So thank you so much for your time. For the little time, you guys sometimes you are so engaged. Tunakat, I mean, we're just getting you. We patrol, but you are doing well, and we still wish you well. Yeah. So yeah. Mofini, mniambie hi. Mniambie hi ama mniambie hi. So why do they normally expose these post dates, babies, paddle and BU? Hey, I'm not getting. Yes, but this one I will just ask a permission. Thank you so much, Stan. I hope you are well. My brother Stan is also one of us who is so somebody is saying 69. Unless you give me an go ahead, but otherwise the time is not on my side. Yeah, mofina alafu kule unit wise to extend at a minute what not. It's okay. That's why I also want to just stop it from there, right? To admit next time. So because unit wise is so crucial, very, very important, right? So to utilize that 1 hour, it's so important. But don't strain yourself too much. After that 1 hour, go and sleep. Are we good on that? Tuko sawa? I also want to sleep. I want also to sleep. Yeah, so WCT, who made that request? Have the norms of this group. We don't extend. Our discussion goes up to 10, right? So thank you so much, and may God bless all of you. Revise smart, sleep well, eat well, and have adequate sleep. Yeah, so that you get a long-term memory, right? Thank you so much. Na ukae stress free. Usijipe pressure nyingi. Yeah. May God bless all of us. Bye.